In this video, we will explore peptic ulcer disease, starting with H. pylori as a key cause and its treatment during pregnancy. Following that, we will discuss the medications used to manage peptic ulcer disease during pregnancy, based on ACOG, RCOG, and evidence-based medicine guidelines. Helicobacter pylori is a common cause of peptic ulcers. However, treatment during pregnancy is postponed until after delivery to reduce the risk of fetal exposure to antibiotics and other potentially harmful medications. Untreated H. pylori infection during pregnancy has been associated with maternal risks. 1. Peptic ulcer disease can worsen symptoms like nausea, vomiting, and abdominal pain. 2. Iron deficiency anemia. Chronic H. pylori reduces iron absorption, worsening pregnancy anemia. 3. Hyperemesis gravidarum, linked to severe nausea and vomiting. Fetal risks. 1. Low birth weight, due to poor maternal nutrition from infection. 2. Preterm birth, associated with complications like severe anemia or stress. Management of H. pylori during pregnancy. NICE guidelines. NICE emphasizes that for mild H. pylori infection with no significant symptoms or complications, conservative management should be prioritized. This includes non-pharmacological support. A. Dietary adjustments. Avoid foods that irritate the stomach, such as spicy, fatty, or acidic items. Eat small, frequent meals to reduce acid reflux. B. Lifestyle changes. Elevate the head of the bed to reduce nocturnal reflux. Avoid lying down immediately after meals. C. For anemia due to H. pylori in pregnancy, use oral iron supplements, ferrous sulfate, with vitamin C for better absorption. If oral iron fails, consider IV iron therapy. 2. Symptom control with proton pump inhibitors or H2 blockers to manage gastric acid levels, rather than initiating eradication therapy. Indications for eradication therapy of H. pylori during pregnancy. 1. Severe peptic ulcer disease, with complications like bleeding or perforation. 2. Unmanageable hyperemesis gravidarum, confirmed H. pylori and conservative measures fail. 3. Severe iron deficiency anemia, resistant to supplementation and linked to infection. The standard treatment for H. pylori in non-pregnant triple or quadruple therapy typically includes a combination of 2 antibiotics, a proton pump inhibitor, and sometimes bismuth. Eradication of H. pylori during pregnancy, a combined approach. ACOG and NICE guidelines. 1. Typical regimen: proton pump inhibitor, omeprazole 20 to 40 mg twice daily. Antibiotics: amoxicillin, 1 gram twice daily. Clarithromycin, 500 mg twice daily, or metronidazole, 500 mg twice daily. Omeprazole, essential for reducing stomach acid and enhancing antibiotic effectiveness. Omeprazole, the preferred PPI during pregnancy due to its safety and efficacy. Pantoprazole and lansoprazole, safe alternatives. There are fewer studies specifically evaluating esomeprazole safety in pregnancy compared to older PPIs like omeprazole and pantoprazole, so it should be prescribed with caution. Amoxicillin is a broad-spectrum antibiotic that disrupts bacterial cell walls. Considered safe during all trimesters of pregnancy. FDA Category B. Avoided in cases of penicillin allergy. Clarithromycin, a macrolide antibiotic that inhibits bacterial protein synthesis. Clarithromycin is classified as a Category C drug by the FDA, meaning that risk to the fetus cannot be ruled out. Studies in animals have shown adverse effects on the fetus, but there are no well-controlled studies in humans. Therefore, clarithromycin should only be used during pregnancy if the potential benefits justify the potential risk to the fetus. Metronidazole, effective against anaerobic bacteria like H. pylori by disrupting bacterial DNA. Metronidazole is generally considered safe during pregnancy, especially after the first trimester. It is classified as a Category B drug by the FDA, meaning animal studies have not shown a risk to the fetus, but there are no well-controlled studies in pregnant women. Guidelines from various health organizations support its use when necessary. Penicillin allergy alternative: omeprazole 20 to 40 mg taken twice daily. Clarithromycin 500 mg and metronidazole 400–500 mg both taken twice daily. 2. Duration of therapy: ACOG recommends a 14 days course. NICE suggests a 7 days course. 4. Avoidance: tetracycline, FDA classification, Category D, evidence of fetal risk. Risks: causes permanent teeth discoloration and impairs fetal bone growth. Recommendation: avoid unless absolutely necessary. Bismuth subsalicylate in pregnancy, often included in quadruple therapy. FDA classification. Not specifically classified, contains salicylate, similar to aspirin. Risks. Avoided in pregnancy, especially in the third trimester, due to potential complications like bleeding. Here is a mnemonic. We need CAM for eradication of H. pylori during pregnancy. C. Clarithromycin. A. Amoxicillin. M. Metronidazole alternative for clarithromycin or amoxicillin in case of penicillin allergy. P. Proton pump inhibitor. Now we will discuss the medications used to manage peptic ulcer disease during pregnancy, based on ACOG, RCOG, and evidence-based medicine guidelines. American College of Obstetricians and Gynecologists. Prioritize lifestyle modifications. This includes dietary changes, stress management, and avoiding known ulcer triggers such as non-steroidal anti-inflammatory drugs, caffeine, and spicy foods. Antacids. Use as the first line of medication. Ensure they are calcium-based and avoid those containing sodium bicarbonate or magnesium trisilicate. H2 blockers or PPI. Use if antacids are insufficient. Famotidine H2 blocker and omeprazole PPI are commonly recommended. Dosage. Use the lowest effective dose for the shortest duration to minimize potential risks. RCOG, Royal College of Obstetricians and Gynecologists. Safety of H2 blockers and PPI. Emphasize their safety when clinically indicated, supported by evidence from large cohort studies.
Style and dietary modifications. First-line approach. Eat smaller, frequent meals. Avoid spicy, fatty, or acidic foods. Stay upright for at least 1 to 2 hours after eating. Avoid eating close to bedtime. Elevate the head of the bed while sleeping. 2. Medications according to guidelines and evidence-based medicine. A. Antacids, first-line pharmacologic option. Antacids neutralize stomach acid by raising gastric pH, providing immediate symptom relief. Examples: calcium carbonate, magnesium hydroxide, or aluminum hydroxide. Calcium-based antacids, calcium carbonate, like Tums and Calcichew. Calcium carbonate also offers prolonged action compared to other antacids, making it a common choice. Magnesium-based options such as Maalox, Epicogal and Mucogal, which contain magnesium hydroxide and aluminum hydroxide. ACOG and RCOG recommend calcium and magnesium-based antacids as safe first-line treatments for heartburn during pregnancy, supported by evidence-based medicine showing no significant fetal risks or congenital anomalies. Excessive intake of sodium bicarbonate is contraindicated due to risks of fluid retention due to its high sodium content, which may worsen edema and increase the risk of complications like preeclampsia and metabolic alkalosis when absorbed into the bloodstream. Sodium bicarbonate raises blood pH. Formulations of sodium bicarbonate like fawurfruits and stomagas. Considerations: avoid excessive intake of sodium bicarbonate. Drug interactions. Antacids can reduce the absorption of iron supplements, which are often prescribed during pregnancy. To avoid interactions, separate dosing by at least 2 hours. Combination antacids. Products containing magnesium trisilicate should be avoided due to potential fetal risks. B. H2 receptor antagonists if antacids are insufficient. Examples: ranitidine or famotidine. Famotidine like RANI-F. ACOG and RCOG consider H2 blockers like ranitidine or famotidine safe for short-term use in pregnancy, with ACOG confirming no fetal harm at standard doses and RCOG recommending monitoring for long-term use due to its effect on nutrient malabsorption, vitamin B12 and calcium, or kidney dysfunction. Evidence-based medicine. Ranitidine and famotidine are FDA Category B drugs, showing no risk to the fetus in animal studies, though there are no well-controlled studies in pregnant women. Evidence suggests they don't increase the risk of teratogenic effects or preterm birth. A systematic review confirms their safety and effectiveness in managing acid-related disorders during pregnancy, with famotidine being preferred due to lower systemic absorption. Dose adjustment. Famotidine is usually prescribed at 20 mg twice daily for pregnant women, but the exact dosage should be tailored to the patient's needs. Ranitidine was withdrawn from the market due to NDMA and nitrosodomethylamine contamination concerns. while famotidine has not faced similar issues. C. Proton pump inhibitors for severe or refractory symptoms. Examples: omeprazole, lansoprazole, pantoprazole or esomeprazole. Omeprazole and lansoprazole are commonly used due to their established safety profile. Omeprazole-like Pepzole, Omas, Napazole, lansoprazole-like Lantanin, Lanzofudil. Pantoprazole is not specifically highlighted in ACOG or RCOG guidelines. Pantoprazole-like Pantaloc, Pantazole and Contraloc. Esomeprazole is also considered safe but should be prescribed with caution. Esomeprazole-like Nexium and Esomium. ACOG and RCOG consider proton pump inhibitors safe during pregnancy for severe symptoms like GERD or peptic ulcers, especially when antacids and H2 blockers are ineffective. They stress that proton pump inhibitors should be used only when the benefits outweigh potential risks. Evidence-based medicine. Most proton pump inhibitors, like omeprazole and lansoprazole and esomeprazole, are FDA Category C, meaning animal studies show no risk, but human data are limited. There are fewer studies specifically evaluating esomeprazole's safety in pregnancy compared to older PPIs like omeprazole and pantoprazole, so it should be prescribed with caution. Pantoprazole is classified as FDA Category B, indicating that animal studies have shown no fetal risk, and limited human data suggest it is safe. Pantoprazole has minimal placental transfer compared to some other proton pump inhibitors, which may make it a safer choice in certain cases.
D. Mucosal protectants. Sucralfate, gastrofate, is classified as a Category B drug by the FDA, meaning animal studies have shown no harm to the fetus, but adequate human studies are lacking. Dose: 1 gram taken 4 times daily before meals and at bedtime. Administer on an empty stomach for optimal effectiveness, as it forms a protective coating on the ulcer site. Avoid taking other medications within 2 hours of sucralfate to prevent interference with absorption. Treatment duration is usually 4 to 8 weeks or until ulcer healing is confirmed. While sucralfate is not explicitly highlighted in major obstetric guidelines, its safety profile makes it a suitable option for peptic ulcers during pregnancy. Medications to avoid specifically for peptic ulcers during pregnancy. Misoprostol, strongly contraindicated due to risks of uterine contractions, miscarriage, or preterm labor. Nonsteroidal anti-inflammatory drugs, as they increase the risk of gastrointestinal bleeding and complications. Aspirin should be avoided, as it can exacerbate peptic ulcers and increase bleeding risks. Corticosteroids. These can increase the risk of peptic ulcer complications and should be used with caution.